Good morning, good day, good afternoon, good evening, and welcome to all our participants. And also welcome to our panelists, together with colleagues from the African Palliative Care Association who are joining us this afternoon. We are continuing in a series of training that looks at improving the end-of-life experiences for people with serious illnesses. And we've had a couple of other trainings before, and today we are focusing on communication, a critical component when it comes to improving the end-of-life experience for people with serious illnesses. And we are being joined today by two presenters who are going to co-present, and I'm going to read their bios so that we have an idea who is joining us today. They are going to present together. I think Patrick will do the main presentation. Connie will present with him at the same time, so they are not coming one after the other. The first, let me read the bio for Patrick. Patrick Coyne is an assistant professor of palliative care at the Medical University of South Carolina in Charleston. And for nearly 8 years until recent retirement, was the director of this program. Previously, he was clinical director of the Virginia Commonwealth University, the Mercy Cancer Palliative Care Service, where he developed an inpatient unit and worked on statewide initiative to improve palliative care. A clinical nurse specialist, he is co-PI on several grants to educate rural and community health providers on primary palliative care. He is co-director of the Palliative APP Externship. He is on the national and international faculty of the End-of-Life Nursing Education Curriculum and has served on the board of the Hospice and Palliative Care Credentialing Center and the Hospice and Palliative Nurses Association. He was named one of the 30 visionaries in the field by the American Academy of Hospice and Palliative Medicine in 2013. Mr. Coyne is a fellow of the American Academy of Nursing, a fellow of Hospice and Palliative Nursing, and the 2018 Hospice and Palliative Nursing Distinguished Career Achievement Award. In 2023, he received the 2023 Hastings Center Kenneth Dixon Foundation Dr. Richard Payne Leadership Award. He has authored or co-authored over 100 publications to improve palliative care. A wealth of experience that we can learn from, as you can see from that bio that I've shared. And he's going to be co-presenting with his colleague, Constance Darling. Constance Darling is adjunct faculty at the University of Maryland, Baltimore Graduate Program in Palliative, a consultant to the Center to Advance Palliative Care, CAPC, and a palliative nurse practitioner at Salem Hospital. She serves as a national faculty for the End-of-Life Nursing Education Consortium, the American Hospital Association of Life Committee, the Massachusetts Serious Illness Coalition Nursing Task Force, and the Massachusetts Comprehensive Care Steering Committee. Comprehensive Cancer Steering Committee. Ms. Darling authored several editions of the Palliative Nursing Scope and Standards and Competencies for the Palliative and Hospice Registered Nurse and APRN. She authored the Hospice and Palliative APRN Professional Practice Guide and a primer of reimbursement, billing, and coding. Essential information for the Hospice and Palliative APRN. She is co-editor of the Oxford University Press Advanced Practice Palliative Nursing, first and second editions. She edited several editions of the National Consensus Project's Clinical Practice Guidelines for Palliative Care. She has authored peer-reviewed articles, chapters, and curricula, and presented nationally and internationally. She is co-director of the Palliative Care APP Externship. Ms. Darling is a fellow of the American Academy of Nursing, a fellow of Hospice and Palliative Nursing, the 2005 certified ACHPN APRN of the Year, a 2016 recipient of a Surgeons Cambia Health Foundation Surgeons Leadership Scholar Award, a 2018 American Academy of Hospice and Palliative Medicine Visionary in Hospice and Palliative Medicine, the 2020 HPNA Distinguished Practice Award, and the 2021 University of Maryland, Baltimore Master of Science and Graduate Certificates in Palliative Care Teacher of the Year. Also a wealth of experience and a lot of distinguished work in her career. So we have a lot to learn from them. And today they are going to talk about communication as we are looking to continue improving capacities in terms of improving patient experiences at the end of life for people with serious illnesses. Welcome to you, Patrick, and welcome to you, Constance. And just a quick welcome also to Dr. Eve, who is coordinating this training, together with my colleague Eugene, who usually is on the French interpretation channel. And if you are here and you can hear me and you need French interpretation, please just indicate for us in the chat. Hopefully you can get a little bit of what I'm saying, enough to indicate that so that we can activate the channel. Otherwise, thank you very much for being here. Let me hand over to the presenters. And my apology, please, for starting a few minutes late. If you have questions, please enter them in the Q&A. It is active. And if you have comments, please enter them in the chat. And the panelists will keep an eye on both the chat and the Q&A. You are free to use either. Welcome, Constance. Welcome, Patrick.
Well, good day. We're both excited to be here, and Connie and I are good friends and colleagues, and we've been doing work together for a long time. So we're hoping to have a pretty robust interactive session. When we think about communication, I think the biggest thing in a palliative perspective, the way I think about it is if palliative care has a procedure, it's good communication, because we can't accomplish anything unless we're communicating really well with our patients and their families. And so I think this is a great place for us to start, and we'll go through this, and hopefully you'll have some comments or ideas or questions. I'd love sharing with you all. So the first thing we really want to do is look at what our objectives are today, is to identify important elements of what is effective communication, look at the importance of communicating with our colleagues, along with the family caregivers, and then how do you tell bad news to patients or their families? And so we'll give you some ideas, and clearly you may augment these based on the patient's culture and belief system. The NCP guidelines, which the United States looks at as the standards every palliative care program wishes to achieve, has objectives which they want every program to try to obtain. And the first would be palliative care addresses environmental and social factors that affect both the patient and family functioning so that they get a good quality of life, and that we have a good team, interdisciplinary team that can work and be on the same page as the patients and the families are, so that everyone is really kind of has the same message, rather than, surgeon says one thing, medicine doctor says this, a nurse says this, so that everyone is really coordinating their communication, and it really should be about all domains. So overview of communication. The first thing is you have to build rapport with the patient and the family. They're not going to go far with you unless they trust you. So honesty is going to be very important. It's important to know what's important to the patient and what are their goals. What do they want to achieve in the time they have? What's important for them? And how do they see themselves coping, and how is the family coping? Can't say enough about good communication. It has to be ongoing. Have to communicate with the team so that they understand what the family or patient are thinking, so that everyone knows what the issues may be, and really take the time to listen. I can't say enough about that. Is sometimes, I know in the American health system, we are so rushed, we don't give patients and families time to talk. And so I think it's really important to take the time to sit down and listen. And I incorporate that really in every interaction I have, is really making sure I have the time to listen. If I don't, I don't want to start the conversation. And we should provide a safe space, meaning people are feel comfortable talking about what's important to them, what may scare them, or what their fears are. Anything you want to jump in and add, Connie?
I mean, I think all of us, just recognizing with our teams that we are working with a team, understanding some of our roles, and just trying to also be clear with the patient and the family what each of our roles are, because sometimes when there's a lot of people, they're not sure what information they're supposed to be telling which person. And so, I think it's really important to be introducing yourselves, saying what your role is and what your goal of the conversation is, just so that then patients are and families know who's really involved and not, because it's sometimes pretty overwhelming for them, because there might be so many different people that they're just not able to remember. And I think we assume that, they are going to remember each one of us, but when there's a lot of people, that just might not happen.
Very, very true. So we look at the nurse's responsibilities and opportunities communicating with patients and families, but this is beyond nursing, just to be honest. But nurses are at the bedside more than any other discipline. So they're really witnessing what's going on. They're the constant at the bedside. And really a good nurse identifies who's going to benefit from palliative care. Lots of great questions you can ask is, how much does the patient want to know about what's going on? How much does the family want to know? Some patients want to know everything. Others, I don't want to know anything. Some families are scared to hear what's going on. So who can you talk to? Should encourage family meetings so that everyone's hearing the same thing at the same time. Be aware that an illness can make a family stronger or can break it apart. And we really need good communication skills with children based on how old they are developmentally. What do they understand? So we know children typically under 5 don't have a really great understanding of what dying or death means. And over 5, they start to get a concept that there's some permanency there, but often we'll work with families to talk to their children, should they choose to. Families get to decide what they want to say and what they don't want to say, but we can help guide them and get the appropriate support. And ethical considerations. With palliative care, you're always thinking about ethics, because palliative care is encountering ethical issues regularly. So we want to make sure we're giving accurate and ethically sound information. So talk about, what's our plan? What do we hope to accomplish in the upcoming hours, days, or weeks or longer? Can they return to a normal life, or how are things going to be different? Is one provider different than another in managing pain or symptoms? Could prejudice occur? What about patients who don't want any treatment? And what are your plans for comfort and palliative care? And how are they going to manage pain and symptoms as the patient's disease perhaps progresses? So barriers that we find that decrease our ability to communicate. I think everyone who went into healthcare, doctors and nurses, the goal was to make people better. But with the population we're talking about, these are a lot of patients that are never going to get better. And so there may be fear of mortality, of breaking bad news, of seeing patients pass away. You may have a relationship with them. A lot of new nurses have no experience in caring for patients with life-limiting diseases. So how do you mentor them, and how do you help them? We may want to hide our emotions when being honest sometimes is painful, and so sharing is good. Sometimes we may be insensitive because we're tired or we've been through too much. We may feel guilty because we couldn't fix them. We want to maintain hope, so therefore we may not tell the truth. And then fears of not knowing the answers to the question. There's nothing wrong with saying, I don't know the answer, but let me help find out an answer. You may not agree with the patient's decisions. or the families. But you have to honor it if they're informed. And then lack of understanding of their culture, perhaps their religion and their goals. What's their relationship with their family? Are they grieving from another death? And is there an ethical issue involved in all of this? So these can stop communication, can make it harder, can make it not occur. Go ahead, Connie. I see your speakers.
Oh, yeah, I was just going to say, I think what the challenge about communication is remembering that we are entering this relationship, but the disease and the experience of the disease really is the patients and the families and not ours. And I find sometimes healthcare providers feel like they know the right answer for this person, but it's not their experience and it's not the family's experience. So it's sometimes really thinking about how do we help communication, but backing back a bit because it's not our story. And I think sometimes people really forget that. So
absolutely. I'm gonna, at this point, I'm gonna skip this video just because I don't think it's going to come across as well. And if it lets me, it seems to want to just jump ahead. Okay, sorry. Maybe it. All right. All right. So as the caregiver, I think it's important and the person really help caring for the patient. And that could be a spouse, that could be their children, could be a friend or relative. It could even be a neighbor. So really what's going on? How do they perceive how things are going? How are things going in the household? Do you have all the care that you need? Do you have enough money to help care for the person? Is insurance involved in the United States? It's a big deal. What's important or meaningful for you? What are you scared of? What are your fears? What are your worries? What do you hope for? And who's helping you? Who's your support system? Because we know caring for someone who has a life-limiting disease is often a 24/7 job, and people who are doing the care taking may be frail as well. And are they doing okay? So how are we supporting them? There was an interesting study in the United States several years ago that found that the caretakers often became so sick because they forgot to take their medications or get health care, and they didn't have time to sleep, and often it shortened their lifespan. We know that 80% of communication is nonverbal, and only 20% is what we say. So, what is our body language telling us? Are our arms crossed? Are we looking at the patient? Are we using gestures? What's the tone of our voice? Are we sitting down to listen, or are we standing over the patient? All of these change the way you communicate. And often it's good to ask your peers, if you've had a conversation with patients or families, when it's over, how did I do? What could I do better? How did I come across? And I find to this day, and I've been doing it a long time, I'm still looking for feedback to get better at this. So there's a lot of deep listening that you should go at. I don't know if we want to use this video or not, Connie. And I can't hear you.
I said, I'm just worried with the way that we've had with some of the internet.
Yeah, I'm afraid it's going to get stalled too. So I'm going to skip it. I'm sorry. We have to look at the cultural considerations. How's it influencing their behavior? Is there someone in charge who's making decisions who is not the patient? Are we sensitive to their culture? Do we understand it? And how do we support the culture? Because that's important to the patient and their family. And how do we best understand how they're making decisions within their culture? So attentive listening, some people would call it active listening, is you want to set the right atmosphere, have the time to have conversations. So if you don't have the time, you may want to wait. Does the patient need to talk or want to talk about things? They actually get to lead the discussion, because you have to know what's important to them. Often we walk in thinking, I need to have these conversations, but the real first objective is let the patient get their concerns voiced. Really encourage them to talk. How are you doing today? What's worrying you? How can I help you the most? Learn to be quiet and sit and listen, and then share your feelings. And that may be things like, I wish things were better. I'm sorry that we're unable to do this today. This has to be hard. I can only imagine. You want to avoid misunderstandings. So often I'll ask patients, tell me what your understanding of what's going on is right now. And maybe they don't understand the disease, the treatment, the expectations of all of it, because often they're overwhelmed and they may not understand our medical jargon. We may not have translated it well. They may have been so overwhelmed with just being sick they didn't hear what was being said. Maybe there were medications involved as well. Don't change the subject. If a patient brought it up or family did, it's important to them and you should hear it out. You should really take a lot of time before you give advice, because when you give advice, you give it on your circumstances, what it would be like for you or your household, and it may be very different for them. Reminiscing's good. How have you gotten through hard times in the past? Tell me about what's important to you. What are you proud of? And then we do a lot of creating legacies. What would you like your children to know about you? What would you like your grandchildren to know? How would you like to be remembered? How can we share your story for your 3-year-old who likely won't remember much of you? Go ahead, Connie.
I was just going to say, so I think some of the ways that this gets applied clinically is, I'm often seeing patients are exhausted, or they have not slept through the night because they've been interrupted if they're in the hospital, or they're having so much pain, or they might be vomiting, and people are walking right in to talk to them. That is not a good time to have a deep conversation, right? It's sort of saying, how are you doing today? Like to talk to you for a bit. Are you feeling okay to do it? Or if they've had several other people talk to them, they might be tired because they've had a lot going on. Maybe they want family to be there to listen to what's going on. So paying attention to, do you want to have this conversation right now? Or do you want to wait for your family? And so I think asking a lot of that. I think the worst that I see is that teams go in to talk to patients and they're sitting on bedpans. Like, that is so embarrassing for them, right? Of thinking about like privacy. And then I think the other part is, I've had patients tell me that they are so aware of how we are as clinicians the moment we kind of walk into the space. I think we put off this aura. And if we're like very officious that, we have a task we're bringing in, we're going to do this, but we aren't even asking them. And I think about that sometimes when I'm interviewing a patient or having a visit, and this has happened more than once to me, but the staff, the tech who does blood draws, will just walk in the room, interrupt, say, I'm here to take the blood, not paying attention to anything that's going on, and then turn around and walk away. And there have been times when I've been so stunned that I didn't know what to say, and the patient will look at me. And there have been other times when they start and I'll say, excuse me, can you come back in a half an hour? We're in the middle of a talk. But just to say that some people are so focused. So I think, Patrick had us right of like really thinking about where they are. And, particularly if they're in a clinic or in a space and they're surrounded by a whole bunch of people just separated by a curtain, you have to be very careful what types of questions you're asking because everybody is listening. When I remember going into the chemotherapy wards and they'd be like that is not a day that I'm going to ask about necessarily sexuality or intimacy or something like that because everybody's listening. And some of them have gotten to know each other and they joke about it, but really respecting the place that you're at and the type of questions that you're asking so that you're being respectful to that as well.
We have to listen and be present and bear witness to what's going on. And here we go again. Okay. So one of the things that we do, I do with our residents and medical students and nursing students is a listening exercise. I'd love to find a way to do this online, but I think that would be a big challenge. But if you're working with your peers, one of the things that we have found very effective is to get one healthcare provider to be a listener. And that would be just basically sitting and listening to a colleague go on for 4 to 5 minutes about something in their life that was a loss and allowing that person to talk. And it's really gives the person who's doing the talking the ability to kind of tell their story about something that it could be the loss of a friend, a loss of a car, a loss of something, could be something, loss of parents, but to go on to what that loss was like and what they meant. And the listener's job is to be there and be in the moment, but not to talk. And sometimes it takes a lot of practice to learn to be silent and also to use your nonverbals. And when people do this, often the listener will say how hard it was not to jump in and talk or fix things. The person who's talking will often say it was wonderful to have the ability to share this with someone and know that they were hearing everything I was saying. And so it's a great exercise. We use it all the time in the medical and nursing schools as we're training because it is hard to be quiet. Try to get us back to a big slide. There we go. So communication techniques, examples that we use in palliative care is we want to build trust. And sometimes to build trust, we have to make sure that we're giving opportunities to get patients to be ready. So sometimes we give what's called a warning shot. I regret that I have some difficult news to share with you. Can we meet later today? This gives the patient time to know that something bad may be coming. And the flip side, if they want family there, it gives them time to perhaps get by the bedside. It's okay to say, I could see this has got to be very upsetting to you. Legitimize it. Anyone receiving this news would be upset. There's no reason why you shouldn't be. And other questions to understand emotion. What worries you the most? I use this question all the time. And empathy, I cannot imagine how overwhelming this is. Saying things like, I know how you feel, you don't know how they feel. But you can understand that it must be rough. And how do you use strength? Where do you find your strength? And is it in your belief system? Is it in your family? What is it? So that you can support that. So other questions to think about asking to make sure you've been heard. What have we not talked about today that's important to you? So that you're meeting all of the patient or their family's need. In the United States, everyone goes out of the way not to talk about dying or use the death word. But we find that if people hear it, they understand it and they can make better goals within the US culture. There's going to be conflict. Patients' families don't want to hear it. Healthcare providers may disagree with each other. So expect it and talk about it. When I encounter conflict, the biggest thing I have to remind myself is that everyone who's in the conflict is really only trying to do what's best for the patient and their family. They just may have different ideas. So if you keep that focus, knowing that everyone's trying to do the right thing, they just have a different perception, it makes it an easier conversation to resolve conflicts. Summarize whatever you say. So let me double check you understand everything we talked about today. I often will offer to write it down so that it's easier for them to review with other family members. And I'm here to work with you, to support you and your family, as is our team. And then use nonverbal skills. Make sure you're listening, that your phone's not going off, that you're not being distracted. So there's a way that we've come up with a way to remember how to really use empathy, and it's the term nurse. So name what's going on, and then understand what their concerns are, respect their decisions, support them, and then explore ways to help them. And then some communication strategies to facilitate end-of-life decisions. One way is to talk about, would you rather be here with us in the hospital? Or would you rather be at home? As you're starting to get sicker and death is approaching, how can we be more supportive? We're hoping you get time to spend with your family. We're hoping that you have no pain or symptoms. And then if we offer interventions, we should clarify the benefits, but also the burdens they may cause to the patient and their family. Terms like I wish, I wonder, and I worry. So I wish statements demonstrate empathy, but also address the limits of treatment. I wish you could see your granddaughter graduate from college. I worry our treatments are not working and time is shorter than we had hoped. And I wonder if there are other ways you can be present and show your love for her on her graduation. So working around those things and still supporting the patient while you're giving hope. Remember to communicate well. Good communication with staff leads to better care for patients.
I think, one of the things to think about as your staff when you're working together is, different people's strengths of communication, and also thinking about that, there will be some patients that different members of the team connect better with, or that patients may feel less intimidated by. So one of the things that I love doing is, if I can have a joint visit with myself and a chaplain, and the chaplain can ask certain questions and I can watch and answer, or I can be talking and the chaplain is watching for certain, how is the patient responding? Because sometimes it's hard for us as one person to be both thinking about how we're responding to the patient and paying a totally attention to the patient's affect, or if we're doing a family meeting, to be, looking at what's happening with the family around them. So, thinking about with our interprofessional team members, who is good with what types of patients, and that, if we are with a patient that we may not connect with it, that you can just sense there's a little bit of a personality part, we can still be very professional, but we might be asking other members of the team of saying, I can feel that we don't this person and I are not really able to connect in a deeper level. Maybe, you might be a better person to come in and ask that. And that doesn't mean that we're a bad clinician. It just means any one of us, connect with different people on a different level. And so just paying attention to that and saying, okay, maybe I'm not the person that this person's going to connect with. Who else can they connect with? And rather than taking it as like, oh, I'm bad or something's wrong, that's just our human nature. And the same thing with our team that, we work with teams and we really want to be respectful of each other while we're working together and support each other. It doesn't mean that the team has to be all best friends and do everything, but you have this respectful working rapport. And I think sometimes with palliative care, because we're doing this intense work, people think like, oh, we have to be perfect, but we're going to have team conflicts. We're going to look at things differently, which is the joy of our different professions. But it also means we have to figure out how to work through conflict or different situations. And I think the role I'm very aware of that I play on my team sometimes is I'm the person who pulls back a bit to kind of look at how different team members may be relating. If I'm hearing a conflict on a team of going, what's going on with that? And understanding both of them are doing their roles, but we've got to pull back because as a team, we always want to make sure that we're open to what's going on and we don't get pulled in the conflict. We're just aware of a conflict may be going on. So that might help in terms of some of that piece.
And in working with your team members, we're just talk about the challenges that are with it. There may not be time. We know that some providers have different expectations about prognosis than their colleagues. There's a lot of research on that in the United States in terms of oncologists thinking patients are going to live a lot longer than with their cancer than usually happens. So that we find that often delays conversations about what's actually going on. Lack of discussions about prognosis and goals of care. So sometimes patients and families are really unaware that the disease cannot be corrected and that time may be short. Difficult finding any records about previous conversations. Has anyone actually had this conversation before? So often it's not in the medical records or the medical records aren't available. And then patients are often handed from one provider to another, or one facility to another. And conversations get lost or confused, or people wait for the next one to have them. So we do a lot of family meetings. We invite our patients to be there if they wish to be, families to be there, or whoever the patient chooses as their representative. Get the right clinicians in the room. So if they have heart failure, we get the heart failure specialist there. And then really the goal is to enhance communication so that everything is covered and discussed and really all questions are answered. When the patient has different abilities or can't understand what's going on, it's really the decision maker, whoever the patient has chosen, or the family, to say, what would they want? If they could tell us their wishes, what are the things they would want? What would be important to them? And so to invite others to help with that decision making if the patient can't help, listen and talk to them, understand what the patient's values were or are, develop trust and rapport, talk about advanced directives. Should we continue doing these kind of interventions knowing we can't fix things? Is it causing more pain and suffering than benefit? And then recognize the differences and similarities as you go forward. So how do I message the effectiveness of palliative care to colleagues? One, to make sure everyone has the same goals and understands what the patient's values and belief systems are, so that we're all going in the same direction. It will improve our clinical care and let us focus on the issues that are important for us to manage. and it will basically improve our care coordination, and it will use the right resources at the right time versus doing things that may not offer benefit or something the patient or family does not wish. So intra-team communication is critical, especially between nurses and physicians, so that everyone's understanding. As I mentioned earlier, nurses are often at the bedside more than the physicians are, so they have insights as to how things are going and what fears are there. And physicians have insights as to the disease process. So trying to get everyone to be saying the same thing and understand what's going on is really important. So to have those discussions as a team are critical, and they have to be collaborative. It should be effective and should be frequent. When we round daily, I'm rounding with the bedside nurse as well as the team. So I'm hearing everything together so that I understand what everyone's thinking. And if there's a disagreement, I'd sure like to do it outside of the patient's area than at the bedside. And then we should document what was discussed so that everyone knows. So if there's a physician covering, he knows from the chart what was said, or the night nurse knows what was said. And as I mentioned before, there are going to be some conflicts, but usually everyone's still focusing on doing what's right for the patient. And when you have a team of more than one, expect conflict. So you got to pay attention to conflict. You know, historically, everyone goes out of the way to avoid conflict, but that doesn't help the patient or the family. So you got to kind of deal with it front on. I can see that we're not agreeing on what we should be doing here. Tell me what your concerns are, and so I can understand. Really, a non-judgmental starting point would be, well, I know you talked about another week of radiation. However, the family says they need to get him home to see the birth of his first grandson this week. So we're not on the same page as to the patient's goals. Listen to each other. Hear what's being said, and then really identify what is it that we're disagreeing about. Look for options to work around so that everybody's needs are met as possible, and look for those options. And sometimes you can't resolve the conflicts. You're going to agree to disagree, but just know you're basically always trying to figure out what's best for the patient or their family. Communicate with professionals who are unfamiliar with or reluctant to consult palliative care. In the United States, that's a big barrier. People think sometimes calling palliative care means we're giving up. And really, we know that if palliative care is involved, patients feel better and live longer, and their quality of life is improved. We have to honor those who ask us to be involved because they're taking a risk in their own minds, bringing us in. And our job is to help them do a better job. Great relationships need to be there. Be specific about what you were asked to do. So the nurse on the medical unit says, he's having a lot of pain or dyspnea. Or the family believes functional status is declining. How would you like us to proceed to help you? And palliative care historically helps providers do their job better because they're giving them more time to focus on the disease itself while you're managing pain and symptoms and other issues within the patient family unit. So to summarize, a lot about what we talked today is communications are really complex. You have to think about what you're saying. So before we see patients as a team, we have pre-meetings, we debrief after a family meeting. What did we all hear? What could we do better? Where do we go from here? Really, your job is to advocate for the patient's wishes. So you can't advocate if you don't know what they're hoping for. Patients' families have to be part of the communication, and nurses, as well as other healthcare members, need to promote communication among their team members, patients and families. So these family meetings are important to meet everyone's needs. Connie, you want to jump in? I see your mic's back on.
Yes, I was just letting you go because I think now we'll get into some great things. We have a question which I'll get to in a minute, but I think one of the things of just talking through, when you are encountering a patient, if we get called, as palliative care, is, first going in and introducing yourself and your role. When I say palliative care, most people don't know what it is. So what I might do is ask, were you told that we were going to be coming in? What was your understanding? Because I don't want to go any further till I hear how it was framed. And as you know, very many people have different ways or different comfort levels of telling what palliative care is. Sometimes it's like, oh, somebody will come in and talk to you about your pain. Okay, that's interesting. Somebody will come in and talk to you about goals of care. Okay. Sometimes, people will say somebody's going to come and talk to you about your illness. And so that helps me understand what they're expecting from me. And then the second part, is after we establish that, I need to have that way of introducing myself, and the whole team needs to be consistent. And so, I'm saying I work with the hospital. I have to be very clear about that, because where we are, agencies are not allowed to go in and talk on their own, right? So I need to be very clear with people when I say I'm working for the hospital, because sometimes when they say I have questions about discharge, they'll say, what agency are you from? So, that might be something particular. But then, I think both and Patrick and I have different language, but we're going to ask the patient, so, tell me why you're here, because we want to hear from them why they're here. Sometimes what the record says isn't necessarily what the patient's perception is. And, how are you? What do you understand about what's going on? What do you understand about your illness? What do you understand about what the team has told you? And asking those two questions are important, because what they understand may be one thing, and what they've been told by the team is another. Because we have patients who might say, yeah, I've had a lot of pain and have been being worked up for a while, but things are okay. And then you ask them what the team has told them, and they said, oh, I have a tumor, but things are okay. But then we know they haven't really heard that tumor is cancer, right? So that connection. So walking through of saying, okay, so tell me what's been going on. And so there's a very much a part of walking in the room and not just reading the chart, but really asking the patient what's going on. And sometimes I'm pretty intrigued, I guess would be the word, of when I hear a patient's story and then I go back and look again at what the chart has said the history is. It's been very interesting to see how people have interpreted what's going on. And I think certainly we do a lot for medical diagnoses, but sometimes there's a difference in what the patient's story is, and it can help you have more of a conversation of, I'm here to help you with your, with your pain. What is your understanding? And, do they have cancer? Do they have heart failure? Do they have whatever? To hear what they even are expecting with that, right? And then that can lead in a conversation. And I think the other part is some of these conversations, if you're in a hospital, they're more acute and they're crisis oriented. So you might be going a little bit farther. If you're seeing them outside of the hospital, in the clinic, in the home, you have more time. And so there's more time to develop a rapport. And the first part is you might be seeing this patient and their family, and they're just doing the treatment, and you're starting from there, but you might not get to some of the other pieces about their values and preferences until a second or third visit, because you're so focused on what's in front of you. So I think just thinking about some of the ways that you're starting off to assess the patient's understanding and starting that communication pattern is just so important, because as Patrick started off, really the fundamental tool is communication, because we can be the best pain person, the best symptom, best loss and grief, but if we can't talk to our patients and families, we've kind of failed. Because that's the essence of what we're going to do. Patrick, do you have anything to add more about walking into the room and starting with patients and families?
I think the first thing is building a rapport, just explaining, what my role is and how I'm hoping to support them. And what are their worries today, kind of really understand where they're at.
And I think the other thing that I think both of us do is make it very clear to the patient and family that we are working in collaboration with their primary team. So that they know that we're not kind of coming in and taking over, but they're working in collaboration so that they don't think that we're trying not to give conflicting information, right? That it's all consolidated. And there might be a time where we're trying to figure out who's going to have the conversation. Do we have the conversation, or do the primary team has a conversation? And I think, at least here in the United States, and I'll be curious what you all would tell us, is we are, now that there's no longer a pandemic of COVID, but let me tell you, we still have COVID. Our numbers are rising again. It's just not as acute, but we're having to reteach some of our primary care clinicians, some of our hospitalists, to actually start having some of the conversations about somebody with serious illness, and at least have that first one before we come in. And so there's a lot of communication that's happening of saying, we have a lot of people to take care of that are acute and need us. And so how do we help the teams have that communication first about what's going on and why they want us, rather than just having us walk in because somebody's referred us but hasn't told the patient and family. And that makes it really hard for us. So I see there's a question in the question and answer. So thank you, Richard. It says, Patrick, some people with dementia have dormant language. Are there strategies a palliative care nurse can use to communicate this person with long-term memory to restore the dormant language communication? Oh, and somebody else. Oh, and then we'll go to the next one. So I think dealing with dementia, I think first of it is how severe the dementia. Remember, people with early dementia and sometimes moderate dementia can still be working with us and be telling us if they're in pain or telling us what they value. As they get worse, then we need to think more about some of the other things. And I know Patrick will get more of that in pain and symptom management specifically, but Patrick, do you have some other ideas about communicating with them?
I really, it's funny with dementia is everyone's kind of in different places where they are, and it can change during the day. So recently I was dealing with a patient with dementia who, if I got to him in the morning, he was a lot clearer than the afternoon, and kind of told me his values were to get home. He didn't understand his illness, but where was he the happiest? And it was being at home, looking out my door at my friends and families who live nearby, and that was his value. Later in the day, he couldn't really articulate that. And so really, what kind of insight do they have into what's going on? And do they have a basic understanding? And can they tell me those things? Sometimes they can and can't. And so I'm forever working with patients with this, trying to figure out if they have the ability to make some decisions. And some patients can make some simpler decisions rather than complex ones. But always trying to make sure they understand that and work with the family always. But it's a challenging population. I'm glad you brought it up, Richard.
And then there was another comment of somebody who has written a paper about some of the issues. Like Yakuba Salatu. I'm sorry if I'm mispronouncing your name, but the name of the paper is Out of the Frying Pan into the Fire, a qualitative study of the impact of masculinity on men living with advanced prostate cancer. And, I think that culture is so important in communication. Again, Patrick will be talking a little bit more. We'll both be talking about it next time when we meet about, there are some people you can't ask if they're in pain. That is just culturally not appropriate. So you can ask if they have discomfort. You can ask if they're able to be functional, but thinking about, what that is, and particularly in this country, you can't necessarily ask war veterans about pain because that's a sign of weakness. So you've got to be attentive to what the culture is, and what are some of the things that would be a sign of weakness or sort of insulting if you ask. I think the other part is knowing different religions and cultures in this country. There is an emphasis on death and dying. However, one of the things that we have forgotten is across the United States, there are many cultures that would never say death or died. That's just not what they say. They say passed on, passing over, going to the next level. And so that might be with some of our Black and African American populations. It might be some of our Baptist populations, but then also in the United States, the Indigenous Americans, Native Americans. There's a whole part about death and dying, of understanding that when we are working with these patients, communication cannot be just with the patient alone. It's very much a taboo. It's very much the community and that they live in, and the family. And I think the other part that may be hard for some of our more westernized palliative care providers is that in the Indigenous populations, family is very loose. It's not biological. And so being open to having large family meetings with different people in there. And so this communication becomes really important, of like, how do we talk to the person in front of us who's the patient? How do we include the family? How do we make sure they're not left out of decisions? And then how do we think about decisions that are going to be appropriate? So, the other thing is that when we're having discussions about hospice, maybe places that, in fact, we're bringing up a conversation about hospice, but there's no hospice services, so we shouldn't be doing that, or it's incongruent. So just thinking about some of those issues. Patrick, do you have any response to that?
No, I think that pretty much covered everything I would have been saying about that.
Okay. Eva's asking, how do you handle complex communications involving bad news on ward settings where I think it's where there's no privacy, Eve, or where there might not be privacy? I think it is so hard to have serious conversations. I will tell you that one time we were having a family meeting, and there, it was a double room, and I had told the patient next door that we were going to have a conversation, and was trying to get him to listen to the radio or something like that. And we're in the middle of a conversation about asking treatment goals. And then there was a silence because we said, what do you think about that? And it's quiet for a while. And the patient in the other bed said, I think you should do this. And I had to get up and go to the other side and say, excuse me, this is not your decision. So obviously some of us have had those decisions when it's not well, but I think it's really hard to have those when there is no privacy, and sort of asking, if you have serious illness, how do you want to talk about it? Or trying to figure out in the room, is there some place that you can be, how big the room is, is there sort of like this code that they will pretend they don't listen to somebody, or what? Because I have a couple of floors right now where the room has 4 beds, and I deal with this a lot, and I'm very thoughtful about what I'm talking about. Sometimes, if possible, if the patient's able to get out of the room, or I might take them to a different corner of visiting area or something like that to have a conversation. But that's really hard, and really thinking about that. So Patrick, I don't know if you have other ideas about that.
It's an ongoing challenge. Trying to get, sometimes I'll bring patients or families into our staff room if I'm just trying to find a quiet place to have a conversation, or at the end of a hallway if we have to, but really look for an opportunity. I do a lot of conversations in the ER, and it's going to be chaos, and I just do the best with the time I have and the place and the location. So I think that the bottom line is you do the best with what you've got. And I think that's what you have to do, because there's going to be issues or times where you're just not going to have the privacy or the quietness that you really would like, but if there's a way to make it better, you should be pursuing it.
other comments or challenges that you've encompassed in terms of, how to work with patients or difficult patients and families, or even working with a team?
This is Eve. I have a question on how do you go about the difficult conversations, say, on a ward setting where there is no privacy?
I think I think when you have wards like that, and I think we both have worked on those, is that I find often the other patients and the families understand the need to try to give you the privacy, and you do your best with what you have. If patients in the room can get up or move, that's great. Doesn't happen too often. I think we're back to, you have to do the best with what you've got. And I understand having, 5 or 6 patients in a room, or frankly, 2 patients to a bed or 3, and still having to have the conversations because that's what you have.
I think that the question becomes also sometimes, what types of conversations do you decide to have? I think you may have more conversations about difficult implications of a disease spreading, or a disease being terminal. I think I'm very conscious of avoiding things that may be more related to sexuality or intimate systems, as for women, if I'm having to talk about GYN issues, or men if I'm talking about GU issues. I'm just going to be more sensitive about that. It feels a little not better, but if in my hierarchy, having serious illness news when all of them may get that's one thing. But if I'm trying to protect their dignity a little bit, about thinking about what some of the other conversations are, and how I do those, because those just may be more embarrassing. And I don't know if that's the right thing to do, but sometimes I might, if I have family members who are worried about things, those might be the times that I might find them outside of the ward to ask the family, are there other things that you're worried about? I'm just very aware that we're in a very public space in there, and just acknowledging it at some point of saying, we're in this space. What do you feel comfortable talking about? Instead of making that assumption. And at least if they have said, look, I know we're here, I'm worried about this, go ahead and talk about it, then it gives me a little bit more comfort. But I think it's really, really hard to be talking about some of those things. And that's why I was saying, like, when I went to the cancer chemotherapy, some of the patients get to have a private room. That is, a blessing when I have that, because I can do a lot in that space and I make use of it. But when they're all in a circle, literally 2 feet apart, covered by a curtain, it's the patients sort of sometimes have had a sense of humor. If I'm asking, how are you doing with your pain? How are your bowels? How are you doing with that? And, some of them will keep talking so that maybe so that they're not apparent that they're listening to the patient that I'm doing with. But sometimes it's so silent. And, it's like, what are my 3 main questions that I need to ask that'll not be so indignant, kind of be an infliction on their dignity. But you got to do, like Petra said, the best that you can do. I'm just looking to see if there's other questions or comments. Richard was just saying, I thank you for the explanation of restoring dormant language, but I also think we have a great need to engage our carers. Absolutely. The caregivers are so important, because if they burn out, the person loses their care. And I think we forget about that. And the challenge sometimes is they actually need to have a separate space to talk. So I would say communication wise, if you're evaluating a patient and if you can have somebody else from the team be able to have the carer in the other room at that same time, so then the carer knows they're not worried about the patient at that moment because somebody's with them, and then they have a space that can be really helpful. I think, there's been so much going on with thinking about caregivers and how to support them. Sometimes they're so locked into having to care for the patient they can't get out. So there's been a couple studies I was just reading about last night where they're doing more with online support groups, chat rooms or things like that, so that they can get in when they need to, and then be able to get out if they have caregiver needs that don't allow them to travel. So I think that that's a really important point about the caregivers, and recognizing they may need a break. Marion says, thank you for the presentation. I think your emphasis on building rapport and trust is the foundation for the entire relationship for palliative care team, the patient, and the family. And so, Marion, that's a really good point, because I think one of the things that's important as a team is to think about the referrals that you're getting, and then who's going to make that first contact. Using your team wisely is important. If it's pain and symptom, you're going to need clinicians who within their scope of practice can do that. But if it's more values and preferences and legacy work, it might be a good place to be having the social worker or the chaplain or the community health worker go in first to be able to do some of that, and then they can bring back if they find any concerns. So, that building and trust is with the whole team, and who's going to be the right person, and then how does that person come back. Patrick, any other thoughts about building trust and rapport with the team and the patient and the family?
I think you covered it there.
Okay. And then I think, let's see, the introduction of a robot in care and communication. Richard, that's an interesting one. I think I will just say that at least here, one of the things that happened because of COVID, where I think that really took off is in two places. One was translations, and one was telehealth. And I'll let Patrick talk about telehealth in a second, because they've done a lot with that. But I think with translation, I was working at a hospital that we didn't have a lot of translators, and we were still using this blue phone that had 2 phone registers, and you would call up some number, who knows where it was, and ask for, a Spanish interpreter, Creole interpreter, something like that. And there have been times that I'd gone through 4 interpreters who even knew what palliative care was. As the patient and family are sitting there, it's not a good way to engender trust, because they're going, what's going on that you're going through this many interpreters? But, that's where we were. I think what happened with COVID is, we were able to use more technology. And so we now have iPads that you click into them, and they automatically go to a place to do interpreter face-to-face, screen to patient interaction. The interesting thing about those, what I will say, since you've already asked questions about dementia, we have found that trying to use iPad interpreters for patients with dementia who do not speak English has not gone that well. And I think part of it is that for the patients with dementia, as they are losing some of their skills, they need to see that 3D person and see the mouth and see all that. And they can't see it on that flat screen. And so sometimes that doesn't go very well. But I think overall, the technology for translation and some of our monitoring has gone well. And Patrick, I think you might want to talk about robot for telehealth, or thinking about some of that.
Yeah, I'm glad you jumped in, because I was trying to figure out what Richard wanted with robots. But we do a lot of telehealth in our system and throughout the state of South Carolina, and frankly beyond, looking at how we can help patients in rural areas. The outcomes have been really good for our population. Either the patients in a hospital in a small area or a clinic, or but we found it's really been helpful because otherwise there would be no palliative care. And we work with their health team wherever they are and have conversations with them and with the patient and the family, and we'll debrief with the person who's in charge of the patient in that location. So our outcomes have been better than I would have expected.
And I think, that's going to be a way of the future. I just did some research looking at pediatric palliative care programs in the community. And what was very interesting is I think as we think about workforce shortages, there are not enough of us palliative care specialists. And where do we go? What I heard a lot of is people are at an interesting turning point where they might go see the patient in person once to get a sense of the person, their living situation, all of that, and then do telehealth after that, unless there's a crisis, and then they have to figure that out. So I think, we'll be seeing much more with palliative care about doing that. I also think in terms of resources, there might be a community hospital that does telehealth like Patrick's doing for a rural area, because they're never going to have a big enough palliative care team, right? So how to think about that. I think, Richard, if you're talking about more AI, I think that's been something that hasn't been written about that much in palliative care. In fact, as I said, I teach at the University of Maryland for the PhD program, and we were just having a conversation about this, of what does the future hold with that? I wonder, because so much of our work is about communication and is nuanced, I don't know if we'll ever be able to teach a robot how to ask some of the questions that we ask, because we ask so many open-ended questions, right? We're not a yes, no, and there's some empathy involved. I don't know if you can teach computers empathy. They might be able to go so far, but even if you think about the movie Her, and there was another movie recently, they could only go so far before there was that part that was very clear it wasn't a human connection. But I wonder, if some of the AI will come in terms of thinking about pain management or symptom management in terms of diagnostics, and that might be happening. But I think for the palliative care community right now, what I've heard from people is saying so much of our work is about compassion and empathy and the human connection that it's going to be hard and not one of the specialties that we may embrace AI as quickly as, say, something with renal failure or heart failure, where you're having a valve or something that you're kind of looking at or something like that. So I hope that helps with some of the answer to your question. I don't see anything else in the chat.
I'm not seeing anything.
Yeah, any other comments or questions that we can comment on for you all? Eve, anything else that you would like us to?
Yes, I want to
discuss?
talk about, say, the adolescents. What are some of the tips in doing effective communication at end-of-life care for adolescents?
For adolescents. Oh.
It's hard enough to talk to them when they're not ill. I think you really have to go, and this would be true with any patient, but where they're at and how the supportive. In my past life, I took care of children, and the vast majority were adolescents with cancer, and really had a lot of conversations with them. And I have learned, at least, that I would go where they were ready to go. So if they would ask questions, and I would talk a lot to their parents, but really, usually parents are their job is to protect their children, and they're making sure they're not getting hurt. But on the other side is adolescents have really good insights to things aren't normal, and they hear what's going on outside the door, or they kind of figure things out. So I'm still a person who believes in honesty, but kind of go there when they're ready. And I kind of go back to, after I talk to the parents, how much do you want to know, or what questions do you have? I like to have those conversations with the parents present. Often parents don't want to be present, believe it or not, because it's too painful for them. So it's a lot of coordination. It's a lot more work. And for me, I find it's frankly a little bit more exhausting.
Yeah, and I think that, but the same principles apply, because the issue though sometimes is parents may tell you you're not allowed to talk about it. And so legally for us in the United States, then we have to be very careful with that. But I think one of the things that we say, and this would be the same for any patient, when family says you can't talk about it, of thinking about what our own ethics are. And in that situation, my response is, I won't bring it up. But if they bring it up, then I'm going to be honest, right? Like, I'm not going to set up that I'm going to be continuing this shroud of hiding something. But I think what happens, as Patrick said, is inevitably what happens is parents say don't talk about it, and then the adolescent will go there. Now the question is, if they're under the age of 18, there's a whole legal thing about the parents can tell us exactly what to do. If they're 18 and above, then they're considered an adult in the United States. And so we're allowed to go there. The other part about that is that you can have young adults who are may have been diagnosed at a younger age, 14, 15, whatever. And because of their illness trajectory, even though they're considered adult, emotionally, they might still be at that age, and they're going to still include their parents a lot. That one gets a little bit stickier sometimes, because you're like, wait a minute, they are an adult and they're allowed to make their decisions, but then we have to kind of honor what their psychological developmental age is at that. Let's see, Landy asks, how do we control noise in a general ward when doing difficult conversations? That can be very hard, and it can be a blessing and a curse, right? Because if there's a whole bunch of noise, that means maybe people aren't paying attention, and I might speak in a low voice with them, but I don't know how to control the noise sometimes with that.
I think it's going to be very individualized of where you are. Is there a door to close? Do you have the ability to find a private room, or you're back to do the best you can with what you got?
Yeah. Or do you go to a corner of the place and talk or something like that? Frederick asks, how do you manage patients and families who are hopeful of recovery despite the advanced state of disease? Good one. I think, one of the things that over the last decades that has proved true is that, patients and families don't ever want us to take away their hope. Now, I have had patients who I knew their diagnosis, but we were never going to discuss it before they died. That's just not what they were going to do. And so I think part of that goes back to the discussion of when you're talking with families about what do they understand, what have they heard, and what are they hoping for. And you can have patients that have metastatic disease and they're still hoping to live. And so then it's kind of having to honor that and still ask them, if we have serious illness, serious news for you, how do you want us to tell you? What type of news do you want to know? Sometimes, we might go to that type of conversation, and we might have patients that say, I don't want you to tell me. I don't want you to tell me how much time I have. I just want to live it. And so we have to honor that, because it's not about us. If they have crises, then we might say, as things have been difficult and you have advanced disease, this is where we're at. But, trying to keep forcing people to, quote, accept may not go so well. And I, as a young clinician, was very clearly brought this example because I had a woman with breast cancer with a family who was dying, and her husband, and I was talking with him alone in the room, and I felt like he wasn't getting it. And I said, do you understand she's dying? And I was standing against a wall, and he took his hand and he punched the wall top of my head and said, of course I understand, but I don't need you to remind me every day of what's going on. So that was a very visible lesson for me about how far to push. That many of our patients and families, this would be the important point of this, live in this duality. They know they're dying, but they can't live in that space all the time. And so they're going to choose to be in this life space, but they flip back and forth. But we can't force them to just face it, because that's not who we are as humans. Unless we're depressed and suicidal, we can't have death be in front of us all the time. We can't continue to live. So I think that's kind of thinking about some of that spiritual piece. Patrick, I don't know if you'd have more.
Yeah, I mean, I'm always looking into where people are. Spirituality is, what keeps them up at night? What are they worried about? What is it they want to accomplish? But I think it's important to understand their values and goals and belief systems and how they're coping.
Yeah.
And our job isn't to take away hope. It's to, we're hoping things get better in terms of pain or symptoms. So we still have hope, but it may be a whole different group that we're looking at when we can't fix an illness. I'm looking at the next question. Richard, could you tell us more about robots so that we're going down the right path? Because we don't have robots here.
The only type of robots that I was thinking that we have is, I know that in here in New England, there's been tests with animal robots. So people can't have pets. They have animal robots that people are doing pet therapy with and respond in that sort of way, because I know sometimes older adults respond to animals better than humans, and some of that. But that's the only thing that we're using with robots.
Yeah, that's what and if it's interpreters, then that's a different thing. So I'm just want to make sure we're answering your question.
Okay. John asked, more consideration for patients with disability, for example, those in disability to hear, when it comes to laboratory results, positive may mean one good thing, yet it's bad result. Great question, John. I think that's one of the things, if people can't hear, how are we communicating? Do they need hearing aids? Is it that they can't hear at all? And so we need to be typing out answers for them, on an iPad, on a computer, or even just writing them out so that they have written things. So spending the time with them. I think if people can't see, or is there something that they can listen to, making sure that they know who we are and we're introducing ourselves. Speaking slowly. If people have cognitive issues, that we might be using books or teaching. There's some things online that people can use to help with simple words to be helping explain things, but we need to be doing a better job. But first, making sure that, if people have hearing issues, do they have hearing aids? Do they have family members who can interpret? Knowing that mostly times people can do better with low pitches of voice, with sight part, do they need glasses? Are we using big print or things like that? So there's a lot of things that we need to be paying attention to more and assessing that, and making sure that they have those with them. So yeah.
I don't see anything right now.
So as we close, I think we have a couple minutes left. Please feel free, if there's other questions or comments, to reach out to us. The next session that we'll be doing is on pain, which will follow up with this in terms of thinking about, you need to have good communication to be doing a good pain assessment. So that's why we built it this way. But if there's specific things about pain or things that you want us to know, or you have a different case, please let Eve know, who can get it to us so that we can make sure that we're addressing or going through some sort of assessment in that way. Eve, anything else that you would like to do to wrap up?
Yeah, I want to profoundly thank Connie and Patrick for sharing with us their expertise in this field. It's a growing field. We are beginning to give it a lot of attention in Africa. There are a lot of taboos around mentioning the fact that the end is coming, and many of us are nervous. We shy away from it and we keep quiet, but behind the curtains, patients and their loved ones know that life is coming to an end. So I think it is important for us to equip ourselves with the skills to confront this monster and do justice to patients and their families. So thank you very much, Patrick and Connie. And we
Thank
look
you.
forward to the next session. And the goal is to improve end-of-life care experiences for our people living with advanced disease. I want to thank you so much for sparing time to attend this session, get sensitized and educated, grow and do better, and let your hospices and palliative care services shine at delivering end-of-life care. I wish you a wonderful rest of the day, and let's catch up at the next webinar series. Eugene, thank you so much for the translation into French. I hope our French colleagues have also had a good time. Thank you, and we will welcome you to Live at Leisure. And please share any questions and forward them to the panelists of the day. Thank you.
Thank you.
Thank you. Goodbye, everyone.
Bye,
Bye.
everyone.
Thank you, Dr. Eve. Thank you, Eugene. I'm going to end the session now.
Thank you.
Thanks. Bye.